So, fascinating, I think, tour through some of the mythologies about US healthcare. And what we're going to turn to now is exploring some of the rhetoric about healthcare in the UK. And I think we can often be a bit smug about the NHS and think, the NHS is here for us all. We have universal healthcare. We're going to test how true that is. So I was going back to the NHS Constitution this morning in preparing for this session. I'm just going to read a little bit from it. The first principle of the NHS Constitution is that it provides a comprehensive service available to all. It has a wider social duty to promote equality through the services it provides and to pay particular attention to groups or sections of society where improvements in health and life expectancy are not keeping pace with the rest of the population. So that's what we think we're here to do. And what we're going to test in this session is how well the NHS actually delivers against that obligation. So we're going to explore the similarities and differences in healthcare for a number of groups of people, and groups of people that I refuse to call hard to reach. I think that's a term that's too easily used. But we want to take a positive frame on this. We want to discuss the things that the NHS can do to improve access to care for those groups. We are going to be using Slido for this session. So if you want to log on to it, the link's on the screen, the event code's on the screen, you go to the Q&A tab. And while you're thinking of your questions, I'm really delighted to introduce my colleague Miranda Davies, who's going to kick us off by talking about the work that she's been doing looking at access to healthcare for prisoners. So off you go, Miranda.
Good morning, everyone. I'm really pleased to be here today to talk to you about access to healthcare for prisoners. On Wednesday of this week, the Nuffield Trust launched our new report, Locked Out: Prisoners' Use of Hospital Care. And this report represents the first time that routine hospital data has been used to look specifically at prisoners' use of hospital services across England. So what I'm going to do this morning is talk to you about some of the key findings that are covered in the report, and also a bit more broadly about some of the things this tells us about the challenges of providing healthcare to prisoners, and also perhaps the quality of healthcare that prisoners receive. But first, why are we talking about this report as part of this wider session on health inequality? Well, I would put to you that there are experiences, circumstances and conditions that can mean that people entering prison, people in prison and people leaving prison are all at risk of experiencing inequalities in terms of their access to healthcare. So let's think first about people who are entering prison. What we know is that actually there are some common shared experiences between people entering prison and other groups within the population that we might commonly talk about when we think about inequality and perhaps vulnerable groups. So what we know is that people entering prison are more likely to have been abused as a child, to have experienced homelessness, unemployment, exclusion from school, and also to have spent time in care. And looking at homelessness as an example, around 15% of people report being homeless on entry to prison, and this compares to around 4% in the general population. So you can already see there are these big differences in people who are entering prison and perhaps other people that we might think of in the wider population. And then, what's life like in prison itself? Well, first of all, I want to put to bed the myth that's widely reported in media reports about prison and prisoners that prison is a holiday camp. It categorically is not. This is a report from the most recent HM Chief Inspector of Prisons, and this is a line from the report, and it reads as follows: that broken windows, unscreened lavatories in shared cells, vermin and filth should not feature in 21st century jails. And I think actually we can't put it any better than that. We don't want people to be living in these types of conditions. In terms of living conditions as well, something I thought was quite interesting was that actually around a third of prisons are built in the Victorian era. And what this means is that there are some really practical problems that people living in prisons can experience if they happen to be in one of those prisons. The prison population is predominantly younger, but actually there's an increasing proportion of older people living in prison. And if you're an older person living in a Victorian prison, what I found was when I visited prisons and spoke to people, things were said to me more than once about being in prison and being an older person. Oh, I missed out on my dentist appointment recently because the dentist is on the 3rd floor and I couldn't get there. The lift isn't working. People can't navigate the stairs. Also, other really practical problems that occur because prisons well, they weren't built to meet the healthcare needs of people, and particularly older people or people with mobility difficulties. Cell doors are not wide enough to move wheelchairs through. There sometimes isn't the equipment that people might need, like walking sticks and so on. The other three things to mention about life in prison that I really would like everybody to take away from this is the big three, really. The overwhelming impact of violence, self-harm, and particularly the availability of illicit drugs, which is debilitating for people who are living in prison and also staff in prison too, who are trying to maintain the general day-to-day running of the prison itself. Thinking about self-harm, in the 12 months to September 2019, there were over 61,000 incidences of self-harm in prison in England and Wales. And this represents a 16% increase on the previous year. And I think this is something we should all be worried about, we should all be concerned about, because it points to wider issues around conditions in prisons, the experiences of people in prison, and also how well their needs are being met. And what about life after prison? Well, these first three bullet points, they're all fairly basic things that you or I need to function in our lives as well. People need somewhere to live. They need employment opportunities, and if they have a long-term health condition, there needs to be some ability to maintain continuity of care as people move from prison out into the community. If any of these three things are not in place, and for a lot of people leaving prison, they're likely not to be. The figures on rates of settled accommodation, they're quite sketchy in terms of the numbers you can draw, but actually most people are not leaving prison to settled accommodation. If you do leave prison and you're homeless, you don't have any likelihood of getting a job, and then particularly if you have a long-term health condition, how far is the £46 discharge grant that people receive going to get them? And I think the answer to this is not very far. So what did we do in our work? Well, what we noticed was that there was a real gap in knowledge around the physical health of people in prison, and also real data-driven knowledge about the physical health of prisoners. So what we did was look at hospital data, and we looked at anonymous records for prisoners identified based on a link to a prison postcode. So we looked at how often services were being used, when they were being used, crucially why they were being used, and then we also did some broad comparisons with the general population, and some specific analysis on women prisoners and also older prisoners as well. So as a researcher, I'm going to start with a caveat that I want everyone to remember before we start thinking about any of the results. Hospital data does not tell us everything, and we need to be aware of that when we think about the actual implications of these findings and what they're really telling us. What is happening in prisons in terms of the healthcare provided and crucially how it's provided is crucial. And we also need to bear in mind the wider prison environment as well, because obviously general conditions, if the prison is on a restricted regime, all of these things will have an impact on what happens to people in prison and therefore what needs to come out of prison to go to hospital. So this is the headline slide in terms of the sheer volume of use of services. Around 12,000 inpatient admissions, about 83,000 outpatient appointments, of which around 50,000 were attended, and then lastly, around 18,000 visits to A&E. But why are prisoners tending to be admitted to hospital? So what we did firstly was look at the top 5 primary reasons that prisoners in England tended to be admitted to hospital in 2017-18. Up there at number 1, we have injury and poisoning. And this equates to around 18% of all admissions, so over 2,000 admissions a year for this reason. But what you might be thinking to yourself now is, well, okay, fine, but how does that compare to what we might see for people in the general population? And that's what we can see here. So the blue bar is our prisoner group, and the purple bar is our general population comparison group. Key thing here, there are different reasons why prisoners are attending hospital than the general population. For the general population, in our broad comparator group, cancer is the most common reason for a hospital admission. For people in the general population, they're tending not to be admitted for injury and poisoning. It's around 6% of all admissions versus this 18% in our prisoner group. So although we might not be particularly surprised that injury and poisoning is up there and it's the most common reason for an admission, For me, this is actually one of the more important findings from the work, because actually I think it's important to place some sort of colour and understanding about the realities of what violence and conditions in prison mean for the people living and working there. And that's what we started to delve into a bit more in the report. So what we can see on the slide here is the 3 most common types of injury and poisoning that we found in the data to affect prisoners. Up there at number 1, we have head injuries. So this is over 500 admissions to hospital a year. This includes fractured skull and facial bones, and most alarmingly as well, intracranial injuries as well. We also then have our poisoning cases, and then lastly, injuries to the wrist and hand. And in the broader report, which we'll give you a web link to at the end, you can also see similar patterns in the A&E data as well. So some people are attending A&E for these reasons, and some are ultimately having to be admitted. So to move on to another finding now that was particularly interesting and intriguing to me was we looked at emergency and elective admissions by prisoners to hospital across the course of a year. And this is what's covered in this slide here. So our top graph references the prison population, and the bottom graph is our general population comparator group. We have the months of the year on the horizontal axis, and the vertical axis is number of admitting episodes. Light blue line elective admissions, and the dark blue line emergency admissions. If you compare the 2 graphs, what we can see is that for elective admissions, the pattern for the 2 groups is pretty similar. Things then get very interesting when we start looking at emergency admissions. If we narrow in on the red boxes, what you can see is that for our prisoner group, there's a very significant drop in emergency admissions in December that is not replicated in the general population. So why is this? I've shown these results to a variety of people, and we've discussed a variety of hypotheses about why this might be happening. And this goes back to the context slide that I mentioned early on, in that it's not just about thinking about the hospital data, it's all the things happening in prison that might explain actually what's going on here. One solution suggested to me was that actually, well, maybe there are physically just less emergencies in December. The person said to me that the regime in prison is softer in December, meaning that people just don't need to go to hospital. Okay, so that was solution 1 suggested to me. Solution 2 was that this is about staffing. There are less staff in December. We know that the prison service, since between 2010 and 2017, there was a drop in around a quarter of operational staff. Numbers are starting to increase slightly now, but there's still this pressure in terms of staffing numbers, and crucially as well, the number of experienced staff too. So that's what we're seeing here. We're seeing a compounded effect in the holiday season of less staff being available to move people to hospital. So it's not that there are less emergencies, it's that there's just less emergencies getting out to hospital. So that's 2 solutions. And if it is one of those 2 solutions, they both have very different implications in terms of lessons that could be learned. If there's something magical happening in the month of December in prisons that means that there are less emergencies, surely there's a case to be made here that this should be happening across the whole year. I don't know the answer to this drop, but I think actually if there's lessons to be learned here that could mean that conditions in prison improve, that is something we should be wanting to happen. So another main finding we talk about in the report is the extraordinary level of missed appointments affecting prisoners. We found that around 40% of prisoners are missing outpatient appointments, and this is around double the rate of outpatient appointments missed in the general population. So in hospital data, we can categorise the reasons that are listed as to why outpatient appointments are missed. And that's what we see here on the screen. So let's discount the bottom category, which is where appointments are cancelled by the health provider, because actually rates are fairly similar between the 2 groups. Where it gets more juicy is when we start looking at the top 2 categories, because it really points to some of the challenges around the sheer delivery of healthcare for people in prison, and ultimately what this means for people living there. So our top category. This is where appointments are cancelled by or on behalf of the prisoner. So in this case, it means the prison is cancelling these appointments in advance. This can happen for a variety of reasons. And a lot of this is to do with how appointments are managed. So you may or may not be aware that if you're a prison, You have to have a certain number of staff to escort people out of the hospital to prison, and you have a set quota of escorts so that you're able to move out per day. There is no publicly available information on how many escorts each prison is set, but anecdotally, people have said to me anything ranging between 2 and 5. So let's say you're in a prison that has an escort quota of 3 people a day. You have a patient that's scheduled to go out for an appointment, but on that day, somebody else is in more urgent need. The first person appointment then ends up being cancelled. So this is one of the reasons we're seeing this slight gap here. The second reason is something slightly more administratively normal. It's that actually, ultimately, sometimes people have moved to different prisons, so appointments have to be cancelled. Sometimes there's court appointments, and sometimes people have just left prison before the appointment takes place. So there's a few things going on there to think about. Our second category is the sheer did not turn up on the day group. So why might that be happening? This is where we go back to thoughts about staffing again. So we know that staffing in prison is challenged. Conditions in prison are obviously challenging as well. And ultimately, and this has been quite widely reported in other areas as well, sometimes there are physically not the staff available to escort people out to hospital, therefore the appointment on the day does not take place. And I should say as well that this also is a problem in prison. So even physically moving somebody from their house block over to healthcare sometimes doesn't happen because there's not the people available to move people around. So in terms of actually sort of sheer results, the last example I want to give to you is how we thought there was a real value in using hospital data to answer specific questions. So you may or may not be aware of the tragic case in December of a newborn baby that died at HMP Bronzefield. That case is still under investigation by various organisations, including the Prison and Probation Ombudsman. But actually, it uncovered a wider point of interest that actually we don't really know much about pregnant women in prison. We don't know how many they are. We don't know how many women are giving birth. We don't know what happens to them. We don't know the outcomes of these births. And crucially, in the case of Bronzefield, there's no firm data about where women are giving birth who are in prison and pregnant. So that's where we thought there was a real potential to use hospital data to look at this in a bit more detail. What we were able to identify in hospital data was 50 women who gave birth in 2017-18 in hospital. But more alarmingly, we were also able to identify a further 6 births that took place outside of hospital. This doesn't necessarily mean all these births took place in a prison cell. They could have taken place en route to hospital too. All we know from the data is that they did not take place in hospital. So this is roughly 1 in 10 births of women in prison is taking place outside a hospital setting. We do not want women in prison to be giving birth in a prison setting. Prisons are not equipped to support the needs of a woman in labour and to safely deliver a baby for a raft of reasons. There is not the staffing, there is not the equipment, there's not the support network, and the list goes on. So we want effectively this to be a never event. So my takeaway message from this particular aspect of the work is the numbers here are not enormous, so surely it shouldn't be beyond the realms of possibility that we can provide safe care for women in prison who are pregnant and go on to give birth. So the report itself, it covers various recommendations. We've got 5 recommendations over 3 areas. So the first is around the need to improve prisoners' access to healthcare. We need to be transparent about how escort numbers are set. We need to know how many escorts each prison is set and also how many are achieved, because that's the only way we can start to look at whether the needs of the population are actually being met. We also need to make better use of hospital data because it's an untapped resource. One of the other things that's covered in the report is some examples of avoidable health outcomes. So, for instance, diabetic ketoacidosis. So if there's people interested in certain areas that might point to perhaps care that's provided in prison, hospital data can provide effectively shine a light on that. So in our data, we're able to identify over 50 cases of diabetic ketoacidosis, which raises questions about long-term condition management inside prison. The main report itself, it also covers a raft of areas that we're not covering in this presentation today. So more information on use of A&E services. We also have as well coverage on chronic conditions and information as well on how uses of services by prisoners compares to the general population. So the takeaway message from that aspect of the work is that actually prisoners are using services less than we might expect if we compare to an age-sex standardised population comparator group. So I've slightly rattled through my slides, but if anyone is interested in looking at the report in full, the web link is there, and please contact me if you have any questions, and I'll be happy to help. Thank you very much.
Thanks, Miranda, that's brilliant. And there are copies of the report available on the tables for people to take away as well. So Miranda's given us a kind of real tour de force, I think, on some of the issues facing one particularly challenged group in society. But prisoners are not the only group that face challenges in accessing healthcare services. So our other panellists are going to talk to us more about some other groups that are vulnerable, are neglected, are treated as hard to reach. So I'm going to ask our panellists in turn to introduce themselves and to talk a bit about the areas that they're particularly interested in, starting with Andy.
Thank you. So I'm Andy Bell. I work at Centre for Mental Health. Hopefully you know about us. If you don't, have a look on our website. We're an independent charity, and our work is about reducing mental health inequalities through research and development. Just a quick word on the mental health aspects of the prison population. We know that very, very large numbers of prisoners throughout their lives have had very poor mental health and often very unhelpful contact with both child and adolescent and adult mental health services, often making contact but never quite being accepted or found a place. We also know that when people are in prison, we have extraordinary long rates for transfers to mental health hospital. Often something that would happen in hours in the community takes well over 14 days, and that's the aspirational target at the moment. And we also know that when people leave prison, even if they've been seeing mental health services, a piece of work we did recently with 63 prisoners supporting them into employment, only 9 who'd been seen by a specialist team within prison unwell enough to do that, only 9 were accepted on community mental health team caseloads. So there's a lot we need to do, but on a more positive note, one of the really extraordinary achievements of the last 10 years of health policy, picking up Nigel's question from yesterday, is development of liaison and diversion teams in police stations and courts around the country. We're nearly there in terms of full coverage. It's an extraordinary achievement that NHS England have pulled off, and they deserve an enormous amount of credit for that. So there is hope. So in terms of mental health inequality, some of these things will be very well known to you, but it's important to restate them. We know that 1 in 4 of us have a mental health problem at any one time. We've all heard that 1,000 times, but that figure masks an enormous amount of inequality. We know children from the poorest households, the poorest quarter of households, are 4 times more likely to have a mental health problem at the age of 11 when they're finishing primary school than children from the wealthiest quarter of households. We know that there are very much higher levels of poor mental health among people with learning disabilities and autism, something like 3 or 4 times more likely. At the other age of the spectrum of age to children, we know that people living over the age of 85 have roughly twice the risk of poor mental health as younger people in the population. And we know there are very specific risks of poor mental health to people from LGBT+ backgrounds, black and minority ethnic communities, many different inequalities in mental health. That are really quite extraordinarily stark differences. And crucially, that is not because of equality of those groups of people. And often efforts to explain mental health inequalities have looked at what it is about that group of people that puts them at greater risk. What we really need to understand, and we've been looking for the last 18 months at what causes inequalities in mental health and what some of the solutions might be, is it's the things that happen to you that are coincidental to having that identity that put you at greater risk. So bullying is a very big risk, isolation is a big risk, experiencing violence and abuse, being poor, being disadvantaged, and being discriminated against in society in general. Those are the things that are inflating the risks of some groups of people to experience poor mental health. But crucially, what we know too is that the same groups of people often get poorer access to healthcare. And yes, we are incredibly lucky to have a national health service, which means that many of the inequalities in terms of access to healthcare that are experienced in other countries are not the case here. We don't, thankfully, have to be able to pay for our treatment, but we do see numerous other barriers that people fall through that stop them getting access to the support that they need. And we also see poorer outcomes for some groups of people. So if you're from an African and Caribbean community, you are more likely to experience psychosis, but you're also more likely, again, to be detained under the Mental Health Act. And once you're detained under the Mental Health Act, you're twice as likely again, when you leave hospital, to be placed on a community treatment order, which is something that means when you leave hospital, you can still be subject to compulsory powers, even though you're living at home. So we know these run right the way through the system, and we know there are solutions to this, and that's what we really need to be talking about. You may have noticed today that one of the headlines that wasn't about coronavirus was about universal credit, and some really important research showing that the introduction of universal credit has come at the same time as an increase in depression cases among people in receipt of benefits. We need to understand that this is just as much the territory of health policy as the NHS and what's going on in health and social care. We need to look at what is happening in our criminal justice system. We need to look at across the whole piece. We need to be thinking about school exclusions. You may know there was a pledge in the government's manifesto to increase the use of exclusions, to build more prison places. These are things that will be toxic to mental health, and we need as a health community to think about how we can address those. There's probably loads more I can and would like to say, but I should probably also let other people speak.
Thanks, Andy. Turning to Andrew.
Thank you. I'm Andrew Hayward. I'm the director of the UCL Institute of Epidemiology and Healthcare, and I'm also co-director of the UCL Collaborative Centre for Inclusion Health. One of the things that we did recently was publish a meta-analysis in The Lancet of the excess mortality rates in homeless people, drug users, prisoners and sex workers, who we thought were highly overlapping groups. And what we found there was a 10-fold higher rate of mortality in those groups than the general population. And this included increased disease rates across all categories of disease. Yet despite this extraordinary level of need, these groups are virtually invisible within our routine health data. These groups are often labelled as hard to reach or inappropriately using health services. But in fact, the truth is it's our health services that are hard to reach and are inappropriately treating socially excluded groups. Negative and stigmatizing experiences of using the healthcare service are the norm, and they serve to push away those most in need of our care from our services. I think it's easy to lay the blame outside the NHS and at broader societal factors, but actually the NHS can do an extraordinary amount to improve the health of socially excluded groups. The Inclusion Health movement is a research, service and policy agenda that aims to prevent and redress the extreme health inequalities suffered by socially excluded groups. One of the things that we did recently was to conduct a review, again published in The Lancet, about what works in inclusion health. We wanted to find what evidence-based interventions there were that health services could and should be doing and investing in. And I'll just run through a few of those. So, pharmacological treatment of infections works, of HIV, TB, hepatitis C, but if you want it to work, you need to accompany it by enhanced case management to make sure that there's good levels of adherence. So, for example, we recently published a randomized controlled trial, again in The Lancet, of an intervention for socially excluded tuberculosis patients with homelessness, addiction, prison histories, mental health problems, where we use smartphone-enabled video observed therapy instead of face-to-face directly observed therapy. And we found it more effective, more acceptable and cheaper than face-to-face directly observed therapy. Yet we struggle to get this model of care commissioned across the NHS. We'll shortly publish a paper that shows if you take patients with tuberculosis with no recourse to public funds and you house them in the Olalo Centre, we can double the rate of treatment completion and reduce mortality rates. Other pharmacological treatments work, long-acting antipsychotics work, opiate substitution works, supervised injecting works. If those don't work, naloxone works. Cognitive behavioral therapy and psychosocial interventions work. Case management, where we're integrating the health and social care to provide a coordinated, holistic package, works. Outreach works. For example, we pioneered the Find and Treat street outreach program, which screens up to 10,000 homeless people and drug users for tuberculosis and hepatitis C and provides vaccination and case management. Works, yet the model is only available within London. Interventions such as connecting people to housing work, yet how seriously are we really taking our duties under the new Homelessness Reduction Act? Linking people to employment and volunteering opportunities work. And finally, and very importantly, I think the putting service users at the heart of service design and as part of service delivery works. But how often are we doing that? I think it's really behoves the NHS to start to take an evidence-based approach to the management of socially excluded groups, and I would really call on all of you here to help in that. Thank you.
Fantastic, thank you. Maybe you've got a few slides for us.
That's right, thank you.
You have two heads.
Tonight, when we get into our beds, there'll be at least 10,000 people huddled up on cardboard in sleeping bags in the rain and the wind. And this is a shameful fact. And there'll be tens of thousands more in inappropriate and insecure accommodation. Homelessness is rising and the homeless are sick. Every one of those huddled up people that we scurry past on the streets as we rush into our supermarkets, our warm cars, our restaurants, every one of those sits there with a death sentence on their head. The average age of death for a homeless person is 42, a shameful fact and surely a public health emergency. What are the barriers? Why are we not doing more? Why aren't we all shouting out about this? We're looking at the barriers from the practitioner's point of view and from the patient's point of view. Patients are stigmatised. We would all deny that, but there is robust evidence that homeless patients are stigmatised. The medical reductionist model, this is where we focus simply on the problem that we're presented with and don't have the time or the resources to look at the bigger picture or deal with it. Patients are turned away from GP registration. We would all deny that happens, but there is good evidence for it. NHS charging regulations. Just last week in my own A&E resus department, we watched a 1-year-old child die of TB meningitis. The parents, who were asylum seekers, had been too frightened to take their child to the doctor before for fear of charges or deportation. We witnessed their grief and the death of a 1-year-old simply there because of a fear that does not need to exist. And finally, education, leadership, changes, doing more, health inequalities, teaching, not just in medical schools or colleges of midwifery, but right back into school, for children to learn that at present in England there is a 19-year difference in death rates between the richest person and the poorest person, and that we all need to stand up and fight these terrible injustices. The patient barriers, why are these silent, these 10,000 people silent? What other patient group would sit there and put up with these terrible injustices of sleeping on a sleeping bag on the street, facing a very premature death from a largely reversible or treatable cause? It is unacceptable. I think the easiest thing is that they've lost all confidence and ability to speak for themselves. But of course, language comes into it, literacy, fear of stigmatization. They are often feeling ashamed, and yet they should not, of their situation. What can we do about this? Every one of us in this room and beyond must stand up and be that voice for the homeless who have no voice of their own. And we must stand up and make sure that these terrible social and health injustices are banished forevermore. We have to do this across primary care and across secondary care, and across finding ways of supporting people on discharge from hospital, and education and leadership, and every one of us can do those things. In our own hospital, we have banned discharging the homeless back to the streets without some secure accommodation. And this should be the rule across every NHS trust in England. We would never discharge any other vulnerable person back to a vulnerable situation. It's a classic example of safeguarding. And to discharge a homeless person who's presented back to the streets is, from now on, should be completely banned. So every one of us needs to stand up and do more. The numbers are still rising. The figures this morning, which we hoped would show a fall, have not transpired. The figures have risen again, and it's up to us to support these people and get them out of these terrible situations. Thank you.
Thank you, Pip. That was incredibly powerful. So we're going to move to questions now, and we'll take a mixture of questions from the floor and questions on Slido, if you want to be using Slido. But just to kick off, I've been trying quite hard, you've all tried hard, to frame what we're talking about today, not about problems for people who are hard to reach, but about services which are hard to reach. Why do you think we find it so difficult to take that framing? Why do we keep in the service persisting in talking about and framing it as hard to reach groups? What is it that gets in the way of that mindset shift? Anybody want to?
Well, I mean, I would say that we're very tied to our traditional models of healthcare delivery. We're very tied to buildings-based services. We're very tied to silos of specialty. So, you know, a lot of these people will have multiple appointments. You know, it's the respiratory physician on one day, it's the liver physician on the other day, it's the mental health team another day, the addiction team another day, and we're not really doing anything to join that up and make that experience and access to healthcare easier.
One of the interesting things that's come out of our work, particularly with young people in some of the most marginalised communities in London and Birmingham, is hearing that actually they have an enormous amount of contact with public agencies. And for them, they all begin to merge into one. And so they have terrible experiences with school, where they're treated as bad and naughty from day one. They're terrified, or their parents are terrified of social services. Of having their babies taken away when they're young and then losing them or getting into trouble when they're at school. Difficult experiences with the police, particularly for teenage boys. And formal health services that feel like they're part of that system, are not trusted. And so very often, particularly young people will feel that if they approach a GP or let alone a mental health service, which is extremely unlikely, that will get straight back to some of those other places. And so there isn't that trust and belief. And I think that's a really important thing that we have to think about. How can we move away from that sense that all public services are experienced much the same?
Any thoughts?
Just that these are not a hard-to-reach group. These people are here with us. We see them every day of our lives, not only on the streets, but I work in hospital, in general practices. They are not hard to reach. They come, they're sick, they're 5 times more likely to attend hospital. We are ideally placed to be there to help.
Thank you. And I think that comment that's there on the slider that people can see at the top of the screen, that thinking about our language and shifting to seldom heard rather than hard to reach is probably a very powerful shift. I think there's another good question there on Slido from Helen McKenna, which is about the opportunities for use of digital and telemedicine. Obviously, Helen's framed it in the context of prisoners, but I suspect it might be something that is useful for other groups that we're talking about as well. But Miranda, do you want to pick up on that, on the opportunities there?
Yeah, I know one of Andrew's colleagues is doing some sterling work looking at use of telemedicine services to improve healthcare, the way that healthcare is provided for people in prison. So I'll let him talk briefly about that, but just to say about the prison context. So prison health services in prison, they're commissioned predominantly by the NHS, but it's not a natural environment for the NHS to operate. It's effectively, they're operating within the prison system. So there's sometimes this pull or this tug between the way that the healthcare operates in the prison and the way that the prison system operates. And I think from discussions with Chantel, Andrew's colleague, this is something that actually plays out in the provision and use of telemedicine services as well. We found in our work that figures currently for use of telemedicine services in prison are extraordinarily low. So there is an opportunity there, most definitely, to think about that as a way to improve access to healthcare for prisoners. But I would caveat that with the point that I made in the talk, that even getting people to healthcare appointments within the prison that they're living in can be a challenge as well. But I don't know if you want to talk any more about Chantel's piece.
Yeah, I mean, it's very interesting. One of the few advantages of the extraordinary number of prisoners who are in the United States is that they have developed very good quality telemedicine services within prisons, and often because they're able to do it at scale and they're able to do it through single organisational units. I think there's a big challenge in introducing telemedicine in that brokering the relationship between the prison and the trust, and dealing with all of the sort of politics and the information governance issues. And in fact, for Chantal, that's taken the first year of her fellowship to sort that out before we can get our first telemedicine case. But it's doable. I think there's other big opportunities for digital technologies. I already mentioned, the smartphone thing for case management of patients. But I think often what we're talking about in inclusion health is the needs to integrate between professional groups, and information and communication technologies really should be being used more to allow that interprofessional discussions, and bringing the client into those discussions as well. So I think lots of opportunities.
Thank you. Pippa, Randy, anything you'd like to add?
One of the perfectly obvious statements we need to make here is that prisoners are among one of the most digitally excluded people in our society.
Yep.
And there are perfectly logical reasons for that. But I think it is important to understand we sometimes receive letters by Royal Mail from prisoners talking about their mental health, desperately wanting to know where they can get help and support. And obviously there are ways of adapting digital technology in that context, but very often we have to understand the particular levels of exclusion that will affect them with. I think the other thing is the thing that we know particularly has an effect on prisoners' mental health. Obviously, it's partly about the conditions in prison, but it's often about fear of what's going to happen afterwards. So not knowing where you're going to live, not knowing if you're ever going to have any money coming in, worrying that your children are being taken away, particularly for women prisoners again. These are really quite fundamental things, and we need to get the basics right first. With people in the criminal justice system, we need to understand the very, very simple things in life that are putting their health at very, very severe risk, and in the worst cases leading to the roughly 90 a year losses of life through suicide in prison.
Thanks, Andy. Any questions from the floor? Fazana?
Thanks for, can you hear me? Yeah, thanks for a really good talk. very close to my heart. Just wanted to make one point and one question. As a GP, when my patients go into prison, remember that we're still their registered GP. There are patients. I've lost 2 patients, one age 36. We know that interface is always difficult. Discharge from prison. Actually, on this occasion, I had got some information that this patient was coming to me within 48 hours, but sadly died before then because of drug withdrawal. We didn't even know what drugs he was on. The second case was a 45-year-old who preferred prison because he liked the routine, and on discharge he had no lighting in his house, nothing at all. He died at the age of 43 of alcoholic cardiomyopathy. So my question is, as a system, there's interoperability, but what about, there's prison doctors, what about more shared? Primary care networks seem to, again, be a place where we could involve our prisons. It's not just about community care. We have some more about that. The DESers at the moment don't reach these people at all. They're the people that I want to work with.
Great question, and it links actually, I think, to the one that's on the top of the screen there about the transfer of health records between prisons and GPs as well. So, Pippa, is there anything you'd like to pick up on that?
I'll let the others answer for the prisoners, but just say it's the same problem for the homeless, discharged from hospital, often antibiotics or something, but they've nowhere to keep them. We had someone discharged who had drugs they had to keep in the fridge. I mean, they could hardly walk around with the fridge on their backs. It was ridiculous. The information for follow-up arrangements is just sent into a black hole. No follow-up appointment is ever... they have no address. They're NFA. So, yes, it's a huge problem, follow-up and transfer of information.
So what could we do about that? What could we do about that in the prison setting?
Well, I mean, I think
the other setting?
there are positive movements towards improving the electronic health records for primary care within prisons, with them moving to a unified system of System 1, which will allow transfer of information into general practice much more seamlessly. So that's a very positive thing.
Any thoughts, Miranda?
Yeah, I mean, there's an inordinate amount of work going on to address some of the issues that have been raised here. So GP to GP registration is currently in progress, but much like within changes to the NHS as a whole, all of this takes an extraordinary amount of time. There's 117 prisons and young offender institutions across England and Wales, so this doesn't happen all in one go. There's a pattern of how this moves across all of the prisons. So as well as GP to GP registration, there's also PDS coming in, so patient demographic services, which will make it easier to actually, when patients go into hospital, to actually pull up their records as well. So hopefully, in the future, we won't be still having cases of looking at paper records, and there'll be a bit more sort of shared continuity of care.
So it does remind me of one of my own experiences commissioning prison healthcare, and I remember, so this is when I worked in Medway, and I had a long conversation with the then governor of Rochester Prison, which was at that time was a Young Offenders Institute, about the difficulties that the boys in his custody had in registering with primary care when they were released. So we had a long conversation about what we could do to build connections with local GPs and so on. And then I said, they do come from around here, don't they? And he said, oh no, most of them are from London. Okay, that's part of the challenge that we have in the NHS with our fragmented structure and actually helping people connect with services.
Can I? So a couple of points on that. One of which is imprisoning fewer people would help. And we really need to keep that voice of health in some of those debates, which may seem very far from what we're talking about. The other thing is there are some really effective through-the-gates type services, often peer-based, which provide mentoring for people both before they leave prison and working with them when they leave. We know for many people the time of prison relief is a time of crisis. It really is. It may seem strange. You might think, well, that's great. They're leaving prison. Hooray. For many people, they're terrified of it, and it is a really challenging experience. So mentoring services and peer-based services doesn't even need professionals particularly to be involved. And that, again, is often where we've got really exciting things happening in the voluntary and community sector that with the right support might help people make those transitions more successfully.
Thank you.
And there's some other organisations as well that are doing great work in terms of employment opportunities. So Timpson's, for instance, springs to mind, that are doing great work helping people, you know, have employment to move into when they leave prison.
Thanks, Miranda. So we'll take a couple of questions from the floor. I could see Andrea had a question, and there's a lady about sort of middle back. Yeah, so we'll take a couple of questions.
Colleague on my table also has as well. So,
Take three.
just 3 quick points. The first is around the importance of joining the dots again. And one of the things which has sort of been touched upon, but I think we should bring out a little bit more, is those people who have been in care up until the age of 16 or 18, who come into both the homelessness and the prison kind of population. And one of the things which just distresses me enormously is that we think young people who have had those experiences are going to be able to stand on their own 2 feet at the age of 16 and 18, and then guess what? So kind of thinking about how we make that link and think about that from a policy and a service perspective. The second thing is that we can learn from some of the good things that are happening. And I mean, Pippa, I thought your presentation on homelessness was just absolutely superb. So thank you. But there are some good places that are doing some fantastic outreach work, particularly nurse-led units. And I had the real pleasure of meeting Sue Temple in last year. She is doing incredible work with her team. So I think we should really be looking for those golden nuggets and seeing how the things that she's been doing over the last 20 years can be shared. And the final thing is, this has been a great session, and particularly with all due respect to the gentleman, but Miranda and Pippa, I did think that your presentations were fabulous. But wouldn't it have been good if we'd had the testimony of people who are experiencing this, their voices in this room as well? And I just leave that thought with you.
Thanks, Andrea. I had the opportunity to hear Len Sisse, the poet and care leaver, speak last weekend. And if any of you haven't heard him, get the chance to. I thoroughly recommend it. It's the most incredibly powerful presentation. Should we take the other question on that table as well and then move to the back?
Hi, I'm Catherine Scott. I'm the Director of Policy at the British Psychological Society. One of the things we're looking at is how we kind of develop the psychological professions for the future. And I think a lot of what we're talking about here in terms of stigma, support, different models of care is a workforce question. And I think it'd be great if the panel could kind of reflect on what different roles might be needed to kind of respond to some of these, you know, I was going to say reach the vulnerable, but you know what I mean. You know, in terms of kind of both in forensic settings. So, you know, we have psychologists who work in forensic settings in prisons, and also kind of what the content of the training and how that might be different. And if there's people from Health Education England in the room, it might be something for them to reflect on as well.
Thanks, Catherine. So we'll take the lady at the back and then come back to the panellists. Oh, all right. Lady in the middle then. We'll come back to you afterwards.
Hi, so I'm Suze Ebeland from the University of Oxford, and this is not my field, but as I understand it, there's pretty good evidence that the housing first model works. And instead of the housing first model, where you give people a house, it's like it sounds, and then you help them to sort out the other problems they may have, we don't use that. We used a stepped approach, where at every point people have to prove that they are behaving well. That seems punitive, and it also feels a lot like we're still using what I hoped would be an outdated model of the deserving poor. I'd be really interested in your comments.
Thank you. So quite a few points there. Our attitudes to people who are seldom heard, or you know, Andrea's point about actually not having the voice in the room, the role that different roles can play, the role of housing, the role of outreach. Would you like to pick up on any of those?
Well, I'd quite like to pick up on the housing first. We recently did a tour of homelessness services across North America in Los Angeles and Pittsburgh and Vancouver. And you know, there's a lot of talk about housing first, and particularly in Los Angeles, where they've got 50,000 people living on the street. They've increased their local taxes specifically to help to pay for housing first models. But the capacity of that is just so woefully short of what is needed. And also, often what is happening is you're plucking people out of their existing community groups and putting them into an isolated flat somewhere. And sure, Housing First is supposed to come with all of this professional backup and linking to services, but too often it doesn't, and people just knock straight back out of the system. So I think we need to be careful about thinking of that as a panacea. I'm an advocate for it, but I think we need to do other things alongside that hugely.
To address the point about housing, there are a number of inspection reports last year and also independent monitoring board reports last year that picked up on people who were leaving prison being given a tent. So I think that kind of points to the challenges of where we are around ensuring that people who leave prison have settled accommodation. So, much like some of the challenges we found in our work that people say, oh, there's no data, it's really hard to collect data, we really just don't know what happens to people. Actually, we know that they're not going into settled accommodation. And I think, when I talked about the slides of the before, during and after prison, ultimately what happens is we get this link back to the beginning again. So if people leave prison and they don't have settled accommodation, there's a possibility that they're just going to go back into that loop of moving into prison again. So.
Miranda, any thoughts particularly about the points made about outreach and the role of different professionals can play?
Well, just first, you're absolutely right. And I did mean to acknowledge in my talk, and I'm sorry I forgot, that there are some amazing pockets of fantastic work. I think there was this, in my slide, it said, that's the thing, we're not joining up and we're not learning from each other. But yes, there are some great projects out there for the homeless. Housing First, yes, totally. Absolutely, well, you heard it from the expert there, but yes, we would absolutely agree with you. Housing First. Even my own MP, who's trying to help the homeless in our city, says, well, let's help them get jobs. And we try to explain to him that when you are sleeping rough, it's very difficult to get up and go for an interview and look good and produce a CV. So absolutely Housing First, then attend to with the caveats we had, then attend to all the other things that they're suffering.
I mean, I think the point about teams, really, and the workforce, I think, is really important here, because, integration doesn't happen at the sort of management level. It does a bit, but it's really about interdisciplinary teams and multi-professional teams, and actually increasingly thinking about people with multi-professional skills. So, why can't we give train nurses to be dual trained in nursing and social work, for example, so that they can meet the needs of these groups more effectively. And so I think we really do need to invest in these specialist teams, but we also need to really invest in upskilling the entire NHS workforce in understanding the drivers of this and the challenges that people face, and making them well placed to be able to link people into other services. So I think there's a big role there for Health Education England. I'm fortunate to have a research fellow who's focusing on how to develop that into professional education at the moment.
Great, thank you. Andy?
I can't help saying on Housing First, we're looking at it in the moment in the context of mental health. The really good thing about it, and with the caveats about it's not the panacea to all the world's ills, nothing is, it's a rights-based approach to supporting people with housing, and that's the crucial thing. It's about getting into a tenancy, a place of your own. You need to do it in the right way, not cut corners, but done in the right way. It does appear to be a really important way forward that we need to think about. In terms of the workforce, I think I've already talked about peer support and mentoring. That's an incredibly important part of the workforce. And what we know is that having peers within mental health services, for example, starts to change the conversations. You don't have conversations about people without them being present in the room, without them being part of the conversation, because they're part of the workforce. The other thing I really want to add, and this is so important, is that one of the most important forms of health workers we've got is people that advise with welfare rights, with housing, with basic things. We know that having welfare rights workers within primary care, within psychological therapy services, mental health services, They reduce the chances of people going into hospital and spending 2 or 3 months there and finding they got no house to go back to. They can stop people being admitted to hospital in the first place by looking at making sure people are maximising their incomes and not getting into trouble with their council tax, which you can go for prison for not paying. So really, really simple things that may seem like, again, they're not part of health, but they most definitely are.
Thank you. Can we take the microphone to the lady at the back?
Oh, thank you very much. So I just had a couple of reflections based on things the panel was saying, that, and it comes up through our own work, which is mostly with people at the older end of the age spectrum who are severely excluded, but I think there's a view that perhaps we don't look at people under the age of 65, and in these contexts we emphatically do. I think there's two things. I think firstly we need to be really honest about resources, and also professionals' own sense of powerlessness in the face of some of these things. And I think that's an unacknowledged area here that certainly comes up for us. That actually it takes time, as Andy says, to build a report. Lots of people are very much in touch with services and many descriptions: social services, criminal justice system, education, health services. But in each one of those places, it's easier to brush them off and move them onwards, because actually to take the time to build the report, to gain the trust, to open the box and unpack all of the issues inside it, takes a lot of time, it takes a lot of resources, and actually a lot of fear on the part of professionals anyway, that what could they do? Because it would take such a multi-agency approach, it would take so much time, it would take so much resource, and they just don't have that, or they don't have access to that. So it's easier never to open the box, basically. I think that comes up quite strongly, and we need to be honest about that and encourage staff to talk about that. The other issue I think perhaps we should reflect on is also, even within the context of this conversation, we're slightly stereotyping people. We have a feeling that we know what somebody, like a prisoner, or a person who's street homeless, that somebody's living with severe and enduring mental health conditions, we kind of know what they're going to look like when they come into a service, and we're going to recognize that. And sometimes, obviously, we do, because it's, you know, they perhaps so far that they've so fallen off the edge of the mainstream that it is quite clear. But often we don't, and we see this a lot with older people, because people, it's what we call the Miss Marple effect in the office. People's stereotype of older people is white, female, frail. They don't think of older people in all of these other contexts. So often older people get brushed under the carpet, and those issues aren't recognized because nobody expects a homeless older person. They don't expect an older sex worker. They don't expect to see an older drug addict. So they just don't ask that question. Nobody expects older women to be living with domestic violence. So I think we also need to be careful. It's not just about not stereotyping people as hard to reach or seldom heard, but actually being really clear in our own minds that we don't necessarily know what these people look like. And we have to be open-minded to that, to every single person that walks through the door.
Some great points. And I think the first point that you make, the first question you raise about funding and use of resources and the role of professionals has some links to the second question that we can see on the screen there about the role of commissioners and whether commissioners are prepared to look at different funding models and to coordinate resources in different ways. So perhaps people could reflect on the comments made at the back and also pick up that question about the commissioner's role.
I mean, I think the point about shortage of resources is well made, and in fact it's substantially worse than you're making out in terms of the services for these groups of people have been systematically disinvested in much more quickly than other parts of the service. I don't know why that is. I suspect it's because they have no political voice. But I would say, you know, we urgently need to redress those imbalances, all the drug treatment services that have been shrunk and farmed out to the lowest bidder on very short-term contracts is a huge problem with how you maintain these services. And the same goes for specialist homeless services as well. And I don't think we really sit and bother to count the cost of that. You know, the cost in terms of avoidable hospital admissions, long, complicated, expensive admissions, huge amounts of A&E usage. We're not costing the cost of inaction, let alone the human consequences of that.
Thank you. Andy, you look like you want to comment?
Sure, I can always find something to say, can't I? I think in terms of at the individual level, I think what's really interesting when we look at the mental health of people in later life, very often we find there's a fatalism. There's an assumption among health professionals, well, yes, of course you're not got good mental health at the moment because you're old and you're experiencing isolation and less physical mobility, and taking this as inevitable. I think it's one of the dangers of when we start talking about the inverse care law, that we almost regard it as being something which is inviolable and can't change. And I think sometimes it's being open to having these conversations and identifying a need that someone's got, or helping someone to talk about a need they've got. Very often when people go and see a health professional, they might go in with one thing, but really be desperate to talk about another thing. And that other thing is often mental health. But again, in some places you have this, you can talk about one thing per GP appointment rule, which immediately takes away any opportunity to have that conversation. At a commissioning level, we've recently had a look at integrated care systems. If integrated care means anything, it's got to be an opportunity to start to bring in services for some of the most marginalised and discriminated against groups of people we talked about today. You could do that at a larger scale than you can in a local area. So I think there's a real challenge there for every integrated care system, not to just look at one or two inequalities or to pick or choose, but look at the whole lot and understand what are we doing around these whole range of issues for people that we haven't served terribly well. And then at the very, very local level, I think it's really interesting that in some areas, primary care services are now beginning to bring in psychologists, for example, or other mental health professionals to work at a very, very local level. So again, there's an opportunity with all the disorganisation going on to think about how we can take a moment to do something a little bit different in all of those different places.
Oh, thank you. Miranda, any comments?
Yeah, sure. I think I agree with both of the points that were raised there. So just some kind of slight musings in response. So about kind of things that we might not expect about prison, people in prison, for instance. So when I was discussing, there's a chapter in the report about older prisoners. So in prison, an older person is normally considered from the age of 50 plus. So we had quite a long debate and there was a real need to actually understand why in prison you would be considered older at 50, whereas in the general population we would not be thinking about people being older at 50. And in terms of the staffing point, I think a real challenge in prison, it's not just about health staffing, it's also about prison staff as well. And the reduction in prison staff and the people that are coming in, which is obviously very much needed, but there has been a loss of experience. And the point made by the lady about the fact that it takes time and experience to develop relationships with people, I think that's where the experience of prison staff in particular is very important.
Thank you.
Just about the resources thing, which the Royal College of Physicians recently surveyed all its members and fellows about doing more for health inequalities, and had a resounding result of everyone wanting to do more. And then the barriers why were, of course, time and funding. But the third barrier to doing more, they said, was lack of leadership and championship. And I think this is a big thing that I found when, you know, I sort of stood up and made a noise about it in my hospital. Other people followed. And I think if everyone in this room and everyone in every hospital, in every practice stands up and makes a noise and says, let's do more, it does actually raise up a groundswell of, you know, public support. And even little things like bringing in clean clothes for our patients. Thank you. Even, I think every one of us,
Yeah, I think that one's right.
can do more, and even if it's just a small thing like bringing in clean clothes for our patients, which are avidly taken up in casualty, to doing major sort of policy changes, then we've all got a role to play, every one of us.
Thanks, Vivian. More questions from the floor. I could see that Becky Rosen had one, so we'll go to Becky, Richard, Naomi.
I'm curious to know what the panel think about the idea of intractability of problems. And I asked that in response to the previous question about people with ongoing complex needs. So in a past period of time when we were running an integrated care pioneer, we were lucky enough to have the resources available to really, really dig into the causes that people who were experiencing a variety of vulnerabilities, high use of services, and mental health problems, what was underlying them. And we did have the resources to really try and put things in place, working with the criminal justice system, with the probation service, etc. And we made some progress with some people, but we had some people who, in the end, we felt were intractably problematic. Despite all of our efforts, we could not change the course of their repeated breakdowns in whatever we'd set up. And I just wonder whether your general view is you never give up and you just have to keep going, or whether you get to a point where you think, actually, we need something for people who are just too difficult. And there's some way you need to respond to the too difficult category that doesn't leave them with nothing, but put some things in place.
Thanks, Becky. Richard?
So Richard Bomer from the Nuffield Trust. We've talked about the impact of employment on health and ill health, and we've also mentioned a number of times the observation that oftentimes the hospital is the largest employer in any given community. Are you aware of experiments of hospitals using their status as a large employer and a source of jobs as an actual intervention in their community? I've heard talk of it, but I know nothing about it.
Fantastic question. And a final one from Naomi before I ask the panel to respond.
Yeah, Naomi Fulop, UCL. I just wanted to raise the issue of social care, and specifically in prisons. Under the 2014 Care Act, people might be aware that local authorities have responsibility to assess and provide social care for people in prisons. And we're just starting to do some research on this. Local authorities are approaching it in different ways, and we've become aware of a couple of prisons in Wales and 3 in London who are approaching it in quite an innovative way and providing training for prisoners to provide aspects of social care to other prisoners. So watch this space in terms of what we find out.
Thank you for that. So some questions about, are there really some intractable problems? And are there some creative solutions in the way in which actually the NHS as an employer and the NHS as a key institution in its community can support the groups that we're talking about today?
Yeah, so to address the point about intractability, I think, and it kind of links to a point that was raised on Slido here, I think by the time that we're looking at people who are in prison, this is the end of a long path of failure at multiple points. And that's why sometimes potentially it can feel like for some people things are intractable. I don't want to be entirely negative though, so I'm going to use an example here of where you can have really good service provision to help people, and I think the maternity pathway in prison is one example. So at HMP Low Newton, they have introduced new maternity provision pathway where there's dedicated time for a midwife to spend at the location providing pet care to people. So I don't think we should ever be giving up, but I can see why actually that can feel like the case at times.
Until a few...
Is it on? Yeah.
Until a few years ago, I would say nobody's beyond help, but with my idealism. But we do have a few homeless, just a very few, 3 or 4, who say they would rather sleep rough. So I don't like the word intractable, but I would say as long as every time they come in, we let them know we're there for them. They can have hot a cup of tea, clean clothes. They can have the list. Every town, every city in England will have hot meals provided every day by one charity or another. Amazing stuff going on. So long as they know the support's there, as long as we keep offering and keep offering. The Homeless Reduction Act we touched on was a major step forward. You probably know and should have been the sort of saviour to all homelessness. 18 months ago, the government mandated that all homeless people should be registered, and those at risk of homelessness in the next 56 days, and referred to the local housing authority. And we thought this might solve homelessness. Unfortunately, a lot of trusts are, and presumably prisons, I'm not sure, are failing to comply due to lack of training, resources, even knowledge. I mean, it seems to me a lot of people don't even know that it's the law now that they should be referring, and this is shocking, really. And we hope very much that the Department of Health is reviewing it 1 year on, or they have reviewed it. We haven't seen the results yet of compliance, but this should be our chance to at least make sure every person eligible for housing is known to the local housing authority. Is a big step forward.
Thank you.
Yeah, I mean, interactability is, I think, partly our own fault. We intervene far too late. We should be providing much more services for troubled children, people being excluded, people at the start of their drug careers, and whereas we tend to leave it until people have got into a real crisis and have developed chronic diseases that are hard to put right. But I don't agree with the concept of intractability. We certainly see some people who you would think that you can't help. So, for example, there's a homeless person in London who was getting about 30 or 40 admissions a year, and everybody was thinking, this is an intractable problem, how are we going to solve it? The thing that solved that was really peer involvement, getting somebody over a long period of time to form a relationship with this person, understand their needs, help to make them think about attending more routine services and things, and that transformed that into a few admissions per year. So people working in the sector do have to get used to the heartbreak of seeing a lot of their clients die. But I think, you know, the saying that we should never give up on anybody is really true here.
Yeah, I mean, I think sometimes we have to acknowledge professionals don't have all the answers, or formal services don't have all the answers, and there may be other ways, particularly where you've got co-designed services, co-produced services, services led by the people who they are supposed to be for, rather than by people who are not. And so we know there are opportunities there. We see some really interesting examples of co-produced projects, such as those led by MAC UK in different parts of London, but there are plenty more. We can show you plenty of those. In terms of using the NHS as an anchor institution and the employer, I think it's about 20 years ago, South West London and St George's Trust, not too far from here, had a scheme called a user employment program, and it was a very simple idea, which was to have a target to increase the number of people using their service who would then come and work in it. And what they found is that being in employment in the trust was actually incredibly good for the trust, because they had people who'd used their services who were then working for them, helping other people. But also it was part of the road to recovery for many people. The assumption used to be you get someone better from a mental health problem and then you find them a job. That doesn't work, it's disastrous. So actually supporting people into work, becoming part of the organisation, or indeed being supported to work in other places, actually help people to enjoy better mental health for the longer term as well. So there are absolutely things that all health services can do as anchor institutions in their local areas.
Thanks, Andy. And I think that's a great note for us to finish on. I was really struck by a couple of things that Andrew and Pippa said. I think what we've heard today from our panel, and indeed from the contributions from the floor, does show that we have got people who will lead and champion these issues, and champion these issues. And we've got people who actually will count the cost of inaction and will say, actually, we need to do something about this. We need to serve the people of this country better. We need to serve the taxpayers better through the investments that we make, and we need to get better outcomes for everybody in society, and not just those who find it easy to access services. So thank you all. We're going to break now for coffee, just in the room opposite. Thank you.